heavy raining last night, and there was a traffic, and someone cannot get home last night, need to sleep in the car, and maybe like a come late. So sorry for the delay this morning. So today we are going to start the session with our expert again to give a talk on the ACR DIR and how to managing the DIR data. So please welcome Dr. Kalpana Kanal for the first talk about the introduction to the ACR DIR. So you're gonna tell us how they do this thing, right? How you help them, and like the history, how it happened.
I'll do my best.
Thank you so much. Yep, welcome.
right.
Yay!
All right. Good morning, everyone. Thanks for all the online folks for coming back today. We didn't scare them away. So thanks for the introduction, Tanya. My job is to talk about the American College of Radiology Dose Index Registry. In full disclosure, I used to be the chair of the ACR DIR, but that was a few years ago. I'm no longer the chair, but whatever knowledge I have is from really the in-depth knowledge is from a few years ago, but also, what changes are going to come. I'll talk about that on Friday as well. So it's really an introduction, and you heard a little bit about this yesterday from Dr. Brady. So there might be a little overlap in our talks, but hopefully it's a good reminder of what the ACR does. So I'm going to talk about what is the registry, identify the challenges in the registry, explain how the RADLEX playbook is used to harmonize data across institutions. Again, we heard a little bit about this yesterday. What are some of the mapping challenges and additional benefits of the DIR? And in somewhere during my talk, I will log into the Dose Index Registry website so you can see what it looks like. So what is the guiding principle behind registries? Why are we so interested, right? It's really a cyclic quality improvement process where you're sending data to a registry, you're getting reports on how you're doing compared to the rest of the country, you're analyzing your result, and then you're making changes to optimize your protocols. If you're higher in dose, you're going to adjust your protocols to reduce your dose. If you're low in dose, also you need to optimize because maybe you're too low in dose and you're missing some clinical assessment. So it's important to keep the balance on both sides high as well as low dose. So what is the motivation behind registries? Well, you may know what your dose is at your local level, but how do you know that is the correct dose? Or how do you know that's the appropriate dose? So the motivation is, what is the national average level of radiation administered by imaging facilities per se, for example, CT of the head? So I may be at 80 milligram and I may think, oh, that's wonderful. But I have no idea where I stand compared to the rest of my colleagues across the country. And that is really the motivation so that you're in a registry where you can compare your data to other facilities. What is the value of the dose index registry? Well, information, right? And a little bit of knowledge. I mean, without this, you have no idea where you are. Being able to benchmark your dose and monitor your dose, receiving a lot of reports from the ACR. And I think sometimes there's too many reports. Some are in PDF format, some are interactive, so you can basically crunch the data any way you want to do it. And then the last part is, and I'm sure it's also here, as Napapong mentioned yesterday, it can impact some Medicare reimbursement for insurance if you're not participating in some kind of a registry. So here it shows you the interest over time in registries starting in 2004, and it's kind of I think plateaued out now because everyone is pretty much participating in it. So here is this pyramid that shows you how are you using this knowledge, right? This is your local dose. It's about 15 milligray. The information you have from the registry is that should be around 12 milligray. So our dose at the local level is a little higher than the national median. I mean, not that high, just a little bit high. So you have the option, you have the knowledge. Okay, so do I want to then figure out, use your wisdom, how to react? Do I really need to make a change? Or is it so close to the median nationally that maybe I just want to monitor it and not make a lot of changes? But if this dose was 25 milligray, then I would say you're really high compared to the national average. You really need, you have that knowledge, and you really need to use your wisdom in how to react to that. Information and knowledge is such an important thing, right? It's so powerful. You can compare yourself against the rest of the nation. So here in Thailand, as you guys are establishing DRLs, you know, a hospital in Bangkok can be compared to a hospital up in northern Thailand, and you can see how you're doing. You can compare across your own sites. If you have 5 hospitals in your system, compare across them. You can compare CT scanners, right? If your Siemens scanner dose is higher than your GE, why is that? You want to compare that. Summary of what is being performed, and you want to track all of this over time. It's not just a one time deal where you're done, you're set up, and you forget about it. No, this is a cyclic procedure. You have to keep up with the information and knowledge and then use your wisdom to make changes. And what are those changes you make? You optimize your protocol. You might optimize some processes that you currently have in place that are not working, and then troubleshoot, which I think is the most difficult part of optimization, trying to figure out where am I wrong, which protocol do I need to figure out, and why is my dose so high? Sometimes can take a little bit of time, but that's where our knowledge as physicists and here in this country, a lot of technologists are involved, their knowledge comes in handy. So let's start with what is the ACR CT dose index registry. We heard a little bit about this yesterday, but I'm going to repeat myself. A tool for quality improvement so facilities can review dose indices and optimize protocol. So the dose index registry collects and compares the dose index, the CT dose index information across facilities. And right now I'm focused on CT, but the ACR has other registries, which I'll talk about on Friday as well, where they collect dose and compare data. It's fully automated, which is the beauty of it. It uses standard methods for data collection, so like DICOM, you know, so everything can go from one system to another, and processing. And it also helps to develop site-specific reference levels. And in America, it meets the Joint Commission requirements for radiation dose monitoring. So Joint Commission, I think Napapong mentioned Joint Commission International that oversees Thailand. The Joint Commission in America is similar to that, and it oversees the accreditation for hospital systems. And as part of not only looking at patient care and scheduling and what imaging patients get, it also looks at dose. And the inspector, we just had Joint Commission inspection last week at my hospital, and they come and they look for, you know, CT reports and show us what have you done in the CT report. Let's look at your radiation dose and stuff like that. What's interesting is the people who are doing that inspection are not physicists, they're not technologists, so they have actually very little knowledge of CT dose, but they're the ones who are inspecting us. It's typically nurses, it's radiologists once in a while, or it's different other types of physicians. So it's a little challenging, but you have to be ready for them and show them all your documentation when they come for inspection. So the CT dose index registry was launched about, 11 years ago. 2011, and we actually signed on as soon as it was launched in May of 2011. So how does it work? We saw this yesterday as well. Again, I'm going to repeat because I think it's a very important concept to know. You can have your scanner send your DICOM structure dose report, or the screen. If you have a really old scanner, you might just have the screenshot for the dose, which is going to go away in the near future. That goes to a site server. So a server that installed, you need, as Sam mentioned yesterday, you need to have IT people help you unless you are the IT person in your department to install a server. It's called the Triad server, but again, that's changing. I'll talk about that on Friday. Where the data is all stripped of personal patient information. So, you know, we follow the HIPAA rules in America. I think you have something similar in Thailand, where you cannot send any patient information. So that's all stripped out of the dose information, as well as a localizer image that is sent. It goes to the DIR database, and then you get reports in a periodic manner. You can also interact with your reports and your data on a regular basis. And, you know, it's a really good way to have some kind of a repository, if you will, of your dose, as well as then you compare to other sites across the country. And so this is the website, and I will log in a bit, and I'll show you how to navigate this, just to give you a feel for what's online. But here's the dose index registry. But as you can see, the ACR has other registries. So there's a CT colonography registry. The biggest other one that we participate besides the CT dose is the lung cancer screening registry. which is very, very regulated in the United States. You can only give a dose less than, 3 milligray. And so we also participate in that for our hospital system. And once you register for one, it's very easy to add any other registry. There's nuclear medicine, there is a clinical data registry, and then now there's 3D printing, which is very interesting. It's like the hot topic in radiology right now. So there's really wonderful source, I would say, for registries in the United States. So let's talk a little bit about data collection. So the data sources vary across facilities, right? Everyone is different. Data submission may be directly from the CT scanner, or it could be sent from PACS, your PACS system, or through third-party dose monitoring tools like Radametrics or DoseWatch, or like one of the 18 that Sam mentioned yesterday. For us, we send it, I'm trying to remember, we send it directly from the scanner to Dose Index Registry. The data format has to be DICOM. It makes sense. I mean, as our scanners are getting more modern across the United States, most facilities will send the DICOM structured radiation dose structured report. But some sites still, rural areas might have a 4-slice scanner, or even a 16-slice, which may not have a DICOM structured dose report, because that you have to buy as an option in many cases. So that can be sent, but that's going away. ACR is going to not take that anymore in the near future. The software will collect, anonymize, and transmit data installed on any computer at your facility, and it works as a service in the background. So once you set it up, you could say forget about it, but in my experience, you can't say forget about it, because sometimes the data will stop transmitting to ACR, and then you have to figure out what happened. So you kind of have to keep an eye on it with your IT person, or you as a physicist has to keep an eye on it. So just so that you know how big the registry is, and this is only for CT, as of August 2022, there were almost 2,300 facilities, domestic and international. Most of this was domestic. I think ACR, DIR has maybe 4 or 5 international countries that participate. They have participated, and how many exams are this? 154 million exams have been collected in the last 12 years, or 11 years, sorry, by the Dose Index Registry. So the data is enormous. So anything that comes out of that data in terms of diagnostic reference levels makes sense, because we have so much data, right? That you have to have good numbers to have good statistics. And so the Dose Index Registry, I think there's absolutely no doubt in anyone's mind, has enough data to come up with wonderful reference levels for the United States. So what is collected? I mentioned dose metrics yesterday, CTDI wall and DLP, and also each irradiation event. So if you have a 3-phase liver, each of those series is also collected by the ACR. Characteristics of the exam to enable comparisons, as well as not only dose, you're sending one localizer image, or a scout image, if you will, to measure the patient width, so that ACR can calculate the size-specific dose estimate that I mentioned yesterday. So right now, you can get that data from DIR. You can get it from your dose monitoring system. And when we first, when SSDE came out, we did a quick study to make sure that what the ACR was calculating as SSDE and what my dose monitoring system was calculating was similar, and it was within 7%, which was fantastic. What is reported on average dose, which we don't really care that much about. Really, you want to care more about the median dose, and then your 75th percentile, which is your DRL, for each facility and registry for each protocol. Dose indices per scan to help optimize protocol, as well as dose indices per exam. So per scan gives you the highest dose, if you will, for a series in an exam. So you can do it that way as well. Because maybe the arterial phase in a 3-phase liver might be more dose than the venous phase. And so maybe we want to adjust that. So that's why the information you get is per scan as well as per exam. However, as like anything else, there's challenges. And how do we overcome those challenges? So capture of standard data from all participants. So we thought the best thing, I should say ACR thought, I'm not an employee of ACR, I'm just a volunteer. Accept the DICOM structured dose report and dose screen. and use optical recognition to read those screens from old scanners. Okay, so that was one solution. Patient size adjustment. We are sending a localizer so we can figure out what is the patient size and calculate SSTE. So that's great. You have dose as a function of patient size. Monitoring runs. Those are the ones, where you're giving contrast and you're waiting till the contrast reaches a peak before you scan. We want to exclude that because that's all in this one position. It's not of importance. So we exclude any monitoring runs from our analysis. Mapping, which we heard a little bit about yesterday, I'm going to focus a little bit on that today as well. We'll talk about that in a minute. And then normalizing for phantom size. This was a question you asked me yesterday on phantom and how do you know what phantom size? So ACR normalizes all body exams to 32 centimeter phantom and head to 16 centimeters. So I wanted to show this based on the conversation yesterday. When you get your report from the ACR, it tells you for all head exams, we standardize to 16 centimeters. For body, we standardize to 32. And the relationship between the two is approximately a factor of 2.3, 2 or 2.3. So if you do have the dose based on one phantom size, you can easily calculate the dose based on the other phantom size. And it also very clearly, the ACR dose index registry report says that if the phantom size is not recorded or transmitted, it is assumed that all body exams use a 32 centimeter phantom and all head exams use a 16 centimeter phantom, which may not be the case. Therefore, it's incredibly important that what data you're transmitting to the dose index registry has the patient phantom size specified. Otherwise, if it is not, ACR is going to make some assumptions and that's going to skew your data. Incredibly important because of what we talked about yesterday on how phantom size impacts the radiation dose. So the report very clearly will tell you what the conditions are, and then you can make a judgment based on your scanners whether it's processing it correctly or not. So let's talk a little bit about mapping clinical procedures or exam name. Sam did a great job yesterday talking about that, but I'll just focus a little bit more in detail. So DIR participating facilities, we have our own facility exam or procedure names, right? Procedure description, study description, etc. If I want to compare my doses or my protocol names to what you have in your facility or what we have in Thailand, it's going to be different. We all might call it different things. So to allow for exam and procedures that are named differently across the DR facilities, we have to give them some way of mapping, right? We have to compare apples to apples, not apples to oranges, right? So you must map your exams and procedures to a standardized terminology, which is what Sam talked about yesterday, which is RADLEX. So CT exams are mapped or tagged using RADLEX playbook IDs. And again, we went through a really wonderful exercise yesterday on how to do that. I will not waste time. Sam, again, did a great job yesterday, but this is the same screenshot that he showed yesterday of the RADLEX playbook, where you can pick what you want and very easily assign the ARPIT. And this is what it looks like in the DIR. You pick the exam, you search for the ARPIT. Okay, this one matches really well, and then you assign it, and it says tagging completed. I will tell you, when we started in getting involved in the dose index registry, I did this on a regular basis. I was very up to keeping up with it, but for us, it's a bottomless pit because our exam names and our study descriptions vary a lot because there's a lot of free texting by the technologists. I gave up because I cannot keep up with the tagging because it's a manual process. And I told you how many protocols we have. So honestly, we were very involved in the first maybe 5 to 7 years of the ACR dose index registry, where I used to make sure everything was mapped. I don't have the time now. And again, when I talk on Friday about the future of dose index registry, they're going to move away from manually tagging to using artificial intelligence, which will make life so much easier for sites like mine, where we have so many protocols and they're not standard names. So again, some of the mapping challenges: scanner fields that are available to us sometimes contain truncated name of procedures. That's not totally spelled out what the procedure name is. Protocol names with more complete information are not always available. At our site, we might do a combo exam, like for trauma, we have a level 1 trauma center in Seattle, and we might do a head, neck, chest, or a neck, chest, pelvis, but the protocol name might just say neck. And it won't tell me it's a combo exam, which really makes it difficult to know whether you're comparing apples to apples. And you cannot really assign, as far as I know, I haven't done it recently, more than one ARPID, I think, for combo exams. It would be very hard to do that for the DIR. So hand-entered procedures name continually introduce new names. That's what happened at our site. Actual procedure may change after the protocol was picked. As I said, you might start out with the chest, but then you may say, well, I also need a little information on the pelvis, so let me add the pelvis exam without changing the protocol name. And that's a problem because then you're skewing your data again. As I mentioned, combo exams, which we do a lot in our trauma center, will not be recognized unless the protocol name has the word combo in it or something like that. So mapping really, I think, is the biggest, it's the quantum sink, if you will, of this whole process with the DIR. You have to do the mapping correctly to get the information out correctly. So it's garbage in, garbage out. If you do not map correctly, it's garbage. And what data you get from ACR is garbage. So mapping, you really need to spend a lot of time on to make sure that the hospitals, and I'll talk about Thailand now, that you're comparing your data, they're all mapped and it means the same thing. And routine head in northern Thailand means the same in Bangkok, routine head protocol. The other thing with the playbook is, and again, this may have changed, but it only allows one tag for contrast enhancement. You cannot tag oral contrast if you've used that as well. So Radlex allows non-con, contrast, and three-phase. It does not allow for four-phase. Now, a lot of sites and facilities in the US are changing from four-phase livers to three-phase livers, but it still does not allow four-phase exams. And similarly, multi-part exams, those are very tough, as I said, that are segmented after, so at our site, they will do a chest, but then they will take out the spine for, one set of radiologists to read, and then there might be the abdomen in it, the neck goes to the neuro guys. It's all that segmentation takes place after one exam. But the dose goes with each of those segmentation for the reporting. So it's really the same patient, but you're getting like 4 different dose reports. So those are the things you have to worry about as well when you're analyzing your own data. As I mentioned, it's a manual process resulting in unavoidable inconsistencies. It's really tedious to do this. When I started doing this in 2011, I sat with my my technologist and me, and we tagged it together because some things for physicists are very easy to understand what a routine head is, but some of them might be a little complex, and you don't know what anatomy is involved or what they're trying to do. And so to tag correctly, you have to sit with your technologist to make sure you're mapping it correctly. And as mentioned yesterday, Radlex is superior to the alternate approach of using what's called CPT codes, which are codes we use for billing in the United States, because that is insufficiently granular. Additionally, the CPT code or the billing code is typically finalized after the exam is already done, whereas the dose data is sent at the time of scanning. As soon as you finish a scan, the dose data goes to the DIR. And you might use CP2 and change it. So it doesn't really work. So the best way to do is Radlex, which is the only option right now. And then there's also ACR Commons. But for dose index registry, ACR is still using Radlex, while for the fluoro registry, they're using ACR Commons right now. So what are some of the reports that are available from the DIR? And I'll show you some of this actually live just to kind of give you a flavor. So let's see if this works. I want to give you a flavor for what the website looks like. So bear with me. Oh, I don't want that. Here. There it is. Okay, it didn't log me out, which is great. So I've already logged in. Here is my name. I am the administrator for my facility. And here I wanted to show you what Sam mentioned yesterday, that under one umbrella, you could have different hospitals. So here is my umbrella. Oops. So here is my umbrella. My corporate account is one, but you can see I have 1, 2, 3, 4, 5, 6 hospitals on the University of Washington. And then my Seattle Children's Hospital is separate. But I can have all of these under one umbrella. And right now it's just showing me the Harborview Medical Center because that's what I picked. But if I go to my corporate account, it will list all of them. And so you can look at hospital-specific data as well. Oh, of course, now it pushed me out. Yay. Great job. Sorry, guys. My phone is over there. This is all the security with the APR. It's like working for the government. Let's see. 611923. So ACR just changed this like 2 weeks ago. So we are all still kind of getting used to this, where there's all this additional security to log in. Okay, so if I press my corporate account, and hopefully it'll show me a list. That's what I was trying to get at. Here you go. That's what I was looking for. So here you can see all my hospitals listed. And depending what hospital I want to look at, you can go and click on that and look at the data. So you can just have one account under which you might have 10 hospitals, and do this. So I showed you that. And then I wanted to also point out what, let's see, I'm going to go back somewhere here, aggregate report. Let's go to DIR. It's very slow, sorry. So when you go here, it shows you interactive reports. And you can play with your data however you want it. You want to look at adult patients, look at adult patients. You want to look at pediatric patients. You want to look at certain dose ranges, time ranges. All of that you can play with interactively. So I'll just give you a brief idea here. So you pick your account. Let's just pick my University of Washington account, apply. And then it could be all my facilities if I want. And we'll just see what it shows here. It's giving you the date range, all patients, but you can split it down according to different ages. You can look at query by study description, ARPIDs or short names, all different options. And then it tells you your data for some of these studies for just a very short period of time, and it found 4,000. The key here is it's interactive, but it's a lot of data, and you want to make sure it's accurate data. So initially, when I relied completely on the dose index registry, I used to download it, and if there were 4,148 exams, I used to pull the same number from my dose monitoring system and make sure they're approximately the same. There's always a little bit of error, but if they're approximately the same, I know most of my data is going to the DIR. I'll be honest with you, I do not rely so much on my DIR reports now. The only data I rely on is a comparison. How do I compare to Sam's facility? Well, his children's, but if I have do pediatrics, how do my pediatric doses compare to his? That's to me meaningful. And the reason I don't use it so much is because I have my dose monitoring system now, and I don't have to deal with coming and playing with the data. But I think for anybody who does not have a dose monitoring system, this is a really cheap way. It's not that expensive compared to the cost of dose monitoring system. And being able to put all your data online, have it all in one place, analyze it the way you want, and compare it to sites, how it looks like. So just was a little bit of idea just to show you. It also shows you how many exams have you submitted in the past, whatever time frame. Again, it's a little slow, the ACR website. And you can do all kinds of analysis here. Okay, let's just pick and see what it does. And so see, it's giving you by ARPIDs. There's obviously a null here because I told you we stopped mapping. So a lot of that are in null. But you can see here, ARPID 1083, whatever that is how many exams I have after this null. It's probably because we stopped mapping. We just cannot keep up with mapping with the way our technologists do so much free texting that for the same name, I have 100 different variations. And so we are working on trying to standardize that at our facility. But this gives you an idea what the data looks like.
The lost data.
Yes.
So it's lost data.
Well, it puts it in null. It's all one.
Yeah, but you don't exactly know from which study or something. It's like a waste. It's just even it's like in the big basket, it's still like a useless.
Yes, it is. It is useless.
Okay.
It's only good the data if you map. and if you map accurately. So for Thailand, it would be very easy to do because you only have, 14 protocols. Unlike us, we have tons of protocols, right? So if you map correctly, then it'll give you all the data. We stopped mapping because it was just not practically possible for us to do it. Once we standardize our protocol names and our study description, it'll be much easier, and that will be our plan. But we have Dose Watch, as our main dose repository, if you will. So I'm not relying completely on the dose index registry. As I said, I use it mainly to compare to other facility, which I want to know, right? How am I doing with respect to your institution? So the DIR is very helpful for that.
You can compare your data with the national data.
Correct. So
right?
you cannot compare institution because all of it is anonymized. So I don't know what it's regional though. You can compare regional, but you cannot compare my specific facility to Sam's. No, because that's all confidential. But you can, as Sam said, you can look at it regionally and see what it looks like. Yeah. Let me see whether I can show that actually real quick.
Yeah.
Yep, exactly. So here, this is what Sam was talking about. If I can make this bigger. There we go. So over here in the report, it gives you all this, information at the top. What are some of the assumptions, phantom size, all that. But the key, and it also gives the paper that we published, which I will talk about later today. And, what are the DRLs already established for patient size? And this is what Sam was talking about. So it can give you, this shows you every black dot on this map is a facility participating in the ACR dose index registry. So you can see there's a lot on the East Coast, very little in the middle of the country. And then that's where I am, right here, somewhere. Those are all my dots. And Sam is somewhere, let's see, where are you, Sam? Here, somewhere, right? Yeah, so this shows you regional. So when you go to your report, then it shows you. The other thing I mentioned, or Sam mentioned yesterday, when I register my facility, I register as an academic site. But in my facility, I have Harborview Medical Center, which is a trauma hospital. So I register that as a trauma hospital. Seattle Children's is a children's hospital. I register that as children. So it's very important when you register that you put the type of facility you are. So you're comparing apples to apples. So I will come under academic. If you're a hospital in Eastern Washington, in the rural area, you're mostly a community hospital. And it looks like even from the data Napapong showed yesterday, in every country, most imaging is done at community hospitals, not at academic centers like Sam and my center or even yours. It's because people live where there are community hospitals. You can see here, the number of facilities are more than 1,000 in this sample, while academic is only like 100, 200 facilities. So you can do this. It shows you location. So for Seattle, I'm in a metropolitan area. But if I pick some, like what would be a rural area in Thailand, that would come under rural. All the different census in America, which area you are, and trauma centers. We are a level 1 trauma center we have in Seattle. So there are 185 level 1. So I want to compare my dose for that trauma center. Because it makes sense if you're a trauma center, your main goal is saving the patient. They come through trauma. You're not going to worry so much about dose. You want to, but at many times you cannot because you're more interested, you're trying to save that patient's life. And so having comparison to other trauma centers is important because maybe your dose might be a little higher than an academic facility. Because again, there you're trying to save, life right there. So that's why it's really nice. And this, when I was the chair, I insisted that they put this in there. So thanks to them for listening to me because it was very important to me that we had something to compare to. It shows you where your data is, which is the one in red. And Sam talked about the wonderful box and whiskers plot, which is fantastic because just looking at that one, you can see your whole dose spread for any protocol. And then the report shows you your top 10 exams, this will be your facility, and this will be all of the dose index registry right here for the full year 2020. This is just a sample report, CTDI wall per scan, DLP per scan, and then size-specific dose estimate, which we don't have our CT scanners displaying that yet. That's going to come, but you get that data from dose index registry or also from Radometrics or Dose Watch or stuff like that. So these are some of the reports. So this just shows you all red, red, red is your facility and how you're comparing. In one picture, you get an idea how you're doing, which is fantastic. And this helps not only physicists, but it helps the administrators look at your dose and yeah, we're doing great. If you show it to the Joint Commission, yeah, you're doing great, that kind of thing. All right, where was my bar? I must have escaped out of that. Okay, so we were here. That was just to give you a flavor of what, okay. All right, so I showed you some of the reports. I already showed you this, so I'll just go through these. There's interactive reports. You can pick whatever you want and crunch your data. So if you come to me and ask me the dose for a certain exam and I don't have it at the tips of my fingers, I could go here, pull up that exam and tell you what our data is and then how it compares, which is so useful. You can do it like really quick instead of trying to collect the data, analyze it. DIR gives you everything, assuming you mapped everything correctly. And then this is also on the ACR website. I didn't show you everything, but you can also do these box and whisker plots on the ACR with your data and play around with it. This is for peds, 15 to 18-year-olds, and it's showing you the data. Some of it is low, but looks like this one for the flash is a little high. So you want to, that tells you again, hey, there's something going on with this scanner. This dose is much higher than the other scanners. So data accuracy, challenges, and benefits of the DIR, it totally depends on mapping. So again, garbage in, garbage out. If you don't map properly, you're not going to get good data. Mapping is challenging by itself, and hopefully in the next year, ACR will be moving over from manual mapping to using artificial intelligence, and that'll make life a lot easy for all its clients. You need time and resources to participate for a facility. So I remember when we first started, I spent a lot of time trying to get this up and running. The physicist has to work with the technologist and in some cases also with the radiologist to do this correctly. But what are the benefits? Comparing your dose data to external resource, I think that's extremely important. You might think you're optimized, but when you compare, you might be 20 milligray higher than the rest of the country, which says something about your facility. So I think that's the biggest benefit. Analysis and interactive dose information at your fingertips. You can play with the data the way you want. So there's one thing I don't like about Dose Watch, and I don't know how Radometrics is because I don't have it, but they have canned reports. You can't really play with the data and make your own reports. It's canned PDF reports, at least in Dose Watch, which I don't like. I like to play with it like ACR lets you do, and you can pick what you want. If you're focused on one protocol, you can just look at one. And I think that's what dose monitoring systems need to provide us with, is more of an interactive, be able to interactively analyze the data. Cost to participate for us, you saw the list of hospitals, and then we have a lot of radiologists. It depends on the number of radiologists. We pay, per site, we pay maybe $250, $300 a year. Maybe a little bit more, but total is about $2,000 across all my sites. The great thing for us is if you don't have a dose monitoring system, it does meet the Joint Commission requirement in the United States to participate in the registry. It does need automation. It is automated for everything except the mapping, which will happen soon, but it's great. Once you set it up and you see the data flowing, it is such a satisfying feeling. And it's a very robust dose review program because, as I told you, there were how much? 154 million data points in the registry. So you know that the statistics is solid and yet you can trust the data that's coming out of the registry. And there are a lot of webinars that ACR puts on to help people who are participating in their registry. So in summary, I want to emphasize, and this was just an example of the ACR because that's the only one we have in America, at least one of the big ones, provide value for quality improvement. ACR CT is one of them in the US. And the reports can provide help with your local data, compare with similar hospitals, which helps us lead to dose optimization. Mapping is still a manual process, can be challenging. Hopefully that'll change soon. And I always advise when I give this talk in the US for people who don't have a dose monitoring system, because in US, I'll give you an idea for Dose Watch, which is what we have, and we use for all modalities. It can cost $90,000 to $100,000. That is a lot of money to spend on a dose monitoring system. So participating in DIR, I think, is a cheaper way of doing it. You know, if you don't want to spend that kind of money. So I always advise, especially sites that are community hospitals, rural area, go spend this $2,000, and so much better than spending $100,000. And the DIR provides data in various formats, which is very useful for any hospital participating. That's all I had to say. Thank you very much.
Thank you so much. Any questions, comment? Yep.
Just to talk to the audience, I think the way we have done is the other way around because we only have 9 sites to start and we don't have the data center that has all interactive stuff. So what we do now are pretty much like manual. We send the data back to the hospital quarterly and then they can do comparison. And the thing is, at the moment, most of the university hospital and big hospital, they have their own DMS system. And I think to make the most benefit, it's best if they have their own because they can play around with a lot of data, right?
Absolutely.
Yeah,
But, you know, again, it's a matter of cost versus value.
yeah.
And I think to spend money on dose monitoring system, your chairman, I don't know how the structure is in Thailand, but in America, the chairman in radiology, the financial administrator, they all have to be on the same page, giving importance to dose monitoring, which not everyone does.
Yep.
And if they are all in sync and they support their physicist team, then that can happen. People will spend $100,000. But not everyone supports that kind of investment in dose monitoring, even though regulations are asking for it. So sometimes they have no choice but to spend the money to do this.
Yeah.
But even I still think it's very challenging once you get it to set it up and understand your dose monitoring system, whether it's Radometrics, Dose Watch, or whatever. It's challenging. As a physicist, we spend hours understanding the dose monitoring system and what's actually giving out. Does this dose thing make sense? Is there something, you know, what you're seeing on your scanner versus your dose management system? Do they match in dose? So that's why I think you spend not only buying, but setting it up, understanding it, and the periodic mapping and periodic troubleshooting, which I think you need a 20% time just to focus on your dose monitoring system. I'm sure, Sam, you spend a lot of time. I'm lucky I have a colleague who takes care of Dose Watch, so I don't have to. But when I first started, at least with DIR, I spent a lot of time on it.
For Thailand, I think the big challenge is that we don't really have physicists around, clinical physicists around.
So you
at the
are relying on
hospital.
technologists.
Yeah, we rely on the technologists, and what we do is, with the team of the Thai DIR, at first phase, we go to help them. Like, we help them mapping the protocol. So we start with a set of 14 first, and then we plan to expand later. But I think at the end, if we have like 100, 200 sites, we may need to develop our own data center that's similar to ACR, where the customer can come in and play with their own data.
Yeah, and one thing I forgot to mention is I mentioned earlier that I used to be the chair. So the way the model works, American College of Radiology is hosting the data center and everything, but everyone who's involved in the DIR is a volunteer. So I was a volunteer chair that I was, you know, driving, and now there's another volunteer chair. So they rely on outside expertise to make sure that whatever they do or whatever they are giving in reports makes sense. And that's what the need is. So you need someone to oversee that whole process and make sure that what you're providing is what's needed. You know, you need 1 or 2 people at the top overseeing the whole as you're starting up this process over here.
I think the first phase that we do is pretty much all volunteer. So we buy the DMS system for the hospital. We do all the work for them. And then if they have problem, we have people to reach out to them.
Yeah.
But this can't be like this forever. So it's not sustainable in case we have like 500 system come in. It would be difficult.
Yeah, you probably need, like in the US, American College of Radiology is hosting. So you need something similar in this country that's similar to the ACR. I think you mentioned,
The Royal College.
yes, where they could take this, kind of be in charge of that, but then have consultants help with overseeing it. Because I think as a individually to do it, it would become too big to manage it. You need like somebody, where they have the resources with IT and managing servers and data. 154 million exams.
Yeah, I think
You
it's
know,
gonna.
of course, that was over 11 years, but that's where you guys are going to go in 11 years. Maybe not that much data, but you're going to approach, million exams or whatever. And individually, it would be impossible
Yeah.
to look after that.
I think we need to do some budgeting to set up this kind of automated system
Yeah.
at our data center. And I'm sure that we will work hard on that. I'm not sure IEA will support us, but somehow our country has money, but sometimes they don't want to spend.
Yeah,
That's the reason they want to spend for something else.
absolutely.
Yeah.
So does it mean the OAP going to be like at the data center? That is our plan, like at the ACR is a data center, and for the moment, right? But I mean, in the future, it's still on the OAP.
Yeah, because the OEP is the legal body, so it's good to have with them.
Yeah, the only thing, again, I'll speak for my country, I won't speak for yours. You have to be very careful who is managing it. If it's state and government, then it might be a problem because they will want you to do things a certain way, which may not be the most efficient way or the most, and I'm saying this in the nicest way. I'm not criticizing them, but it's just because the government works differently, the states work differently. They have a governance. You can't change things like that. That's why having someone like American College of Radiology, which is its own entity, they can do whatever they want as long as it's legal. And, they have the resources too. Government, they won't have as many resources. That's another thing is money. So government or state or anything will not have that resources to spend like something private, like the American College of Radiology.
Yeah. We've been thinking about that too, but probably maybe in the next phase because if we have the accreditation to start with, like advanced HA hospital accreditation, and then they let the Royal College to be the accreditation body, then we can go from there.
Absolutely.
But it's not going to be in the near future, I think. So what we really want is we need our DAR to really function, and then we want more facilities to attend. That's why we invest all the human power to help all the hospitals.
Yeah, makes sense. You guys have started off very well.
So that was an excellent talk from Dr. Canal. And she gave my talk basically. So
Can
I don't really
we-
need to give my talk for the morning.
there is one more question from the online audience. Yeah. So does the DIR provide those report based on a specific weight range for adult for specific protocol?
Are there URLs for
DIR. Yeah. So does the DIR protocol dose report based on a specific weight range for adult for the specific protocol?
For the adults, yes, we did it not by weight, we did it by effective diameter or water equivalent diameter, so by size, but not, thickness, not by weight, because weight is unreliable. People lie about their weight. So, so the size is better way of doing it. And for adult, we did it by size, and then for pediatric, we did it, and I'm going to talk about that in the next talk. For pediatric, we did it by size as well as age, because that's pretty common in hospitals to scan by age.
Initially in the beginning though, they established a standard person, and in the Western culture that was 70 kilos, plus or minus I think 15. Yeah. And and Nate Papong said that I think you guys had established yours as 60 kilos for the standard adult. So I mean that becomes, and that's helpful because if you are seeing all the data and you see, a head seat, head's a bad example. So an abdomen or an upper abdomen, a complete abdomen, you know that you're comparing it to quote unquote a 60 kilogram man or woman. And so that's helpful. But then as Kalpana just mentioned, going forward, we've expanded that now. Now that we send in the scout image, the topogram, the scanogram, the SurView, whatever your CT scanner has, and it's able to take the measurements and it calculate the actual size of the patient. So now we can be more we can be more granular with the way we compare the data. And that's very helpful. That's a great question. We love questions from the online group. So really just building off of what Kalpana presented, and I'm just going to talk a little bit more about the dose registry. Oh, sorry, out of order. So the idea here is that you've got your dose monitoring system, you've gone through the tagging process, you've got everything associated, you send the data to the National Dose Registry, the National Dose Registry sends you back a report. Now what do? How do I interact with that data? So obviously we talked about how we need to start that with a dose monitoring solution. Once again, tomorrow, we're going to talk quite extensively about this, so I'm not going to go into detail. There are a lot of options. The National Dose Registry here in Thailand, of course, is operating based off of Radiometrics, so it makes a lot of sense that all of the various different hospitals here in Thailand will just interface directly with Radiometrics, so they'll have Radiometrics in their hospital, and they'll have Radiometrics up at the OAP. That said, the way it works in the US and the ACR, we have just a plethora of different dose monitoring softwares. And once again, not to harp on a point, but you have to make sure if you do pick a dose monitoring solution that it will meet the needs of the hospital. Pretty much every one of them, as of today, will cover CT, but not all of them will cover all of the modalities out there by way of monitoring either dose or for MR and ultrasound utilization. So that's all said. It's important to say that only 67% of all the software options can send formatted data to a national dose registry. So you just have to be very careful with what you're picking as a dose monitoring solution in your hospital. All right, so when setting up your national dose servers, you need to work with the individuals, the hospitals, and the clinics to make sure that you choose the software options. And once that's there, the data's up and the data comes back, let's look at 4 steps, the components of kind of the DIR report. So I'm going to, once again, kind of as Kalpana did, I'm going to share with you the way we do it in the US, the way I've experienced. I'm going to use screen captures from my specific DIR reports. And what I want to do is try to demonstrate areas where maybe the Thai report can be structured to be somewhat similar. So these are the things that we would want: inclusion of criteria list of the DRLs, data summary, obviously the graphs, the plots, and all that stuff, and executive summaries. So you need to establish the criteria to accept data for a national report. So once again, the example for the ACR is the age of the patient to which the exam was administered had to be 18 years or lower if you are to consider it a pediatric patient, and 18 years or above for an adult. The name of the exam had to be tagged, and you saw an example. What happens if you don't tag it? It just becomes null, or it becomes just into this empty bucket where you can't, once again, analyze that. If you were to run a report on null, you'd probably have min and max bars that go from 0 to 100% because it's everything. And so you have to make sure that everything is tagged properly. And then the executive summary report is going to provide exam totals. It's going to tell you how many exams are being compared in that group. In the early days of Thailand, you probably won't be able to maybe meet some of the minimums, but for the ACR, they look at minimum groupings of 2,000 up to 10,000 total records for a facility, for pediatric and adult reports respectively. In other words, if you only have 1 or 2 studies, it's very hard to get meaningful statistics out of that. And so when you compare your values from your local hospital, you want to be comparing it to a large curated data pool. So the ACR doesn't do comparisons unless there's a minimum of, as you can see, 2,000 to 10,000. And then as the ACR has done, they've simply selected the top 10 when you get executive summaries. Of course, as we know here in Thailand, they do a top 10 plus 4, unique and specific to Thailand. So a total of 14. So you just need to be upfront in your report, define what your inclusion criteria were. And now, obviously, you want to list what the DRLs are. And so we went over some of the DRLs yesterday. We've talked a little bit about that. The next talk, Dr. Kanal is going to actually specifically talk about what are DRLs, kind of give the introduction to it, even though we've been talking about it, of course, for about 4 years now, actually 5 or 6 years here in Thailand. And the idea here is, as Kalpana mentioned, we break things down now by size or age, if it's for a head, for example. But as has been mentioned, as we just talked about it, you can also then use weight. If you need to standardize what a person would be, male or female, like it's in Thailand, it's 60 kilos. In the Western culture, it's typically 70 kilos. So you need to define your DRLs based on some kind of demographic information. And then, of course, you'll get your values out. And of course, they're going to be specific to the CT descriptors, which of course, Kalpana discussed yesterday, CTI-VAL, DLP, and SSDE. You want to give some kind of description. I know that might seem silly, but when you send this report, most of the people reading the report are not necessarily going to be technologists and physicists, but they may be physicians and they may not even be radiologists. So you do need to be explicit in what you're describing. So this report, if it's a CT, dose index report, we use the CTDI volume, the DLP, and the site-specific dose estimate, and describe it and give the units. It's just a very common way to make sure before they go too far down the report that everyone is kind of level set, everyone knows what we're talking about. So once again, Kalpana demonstrated this when she was doing her live presentation on the web. You want to now break up your registry data by region so that you can make meaningful comparisons. So obviously Thailand can be split up any different ways. Nepapong yesterday showed that it's broken up currently into 12 regions, so that's great. In the US, we have a variety ourselves. We have, about 9 regions. And then eventually at some point, you'll start to see, as you start to fill this in with more and more centers, you'll see obviously, as Kalpana mentioned, there's quite a bit up here in the northern, eastern side of our country. This is where our population center is along the East Coast. And so it makes sense that we have a lot of data up here. You may need to be more granular. If you have, for whatever reason, a very large collection of patients, maybe or data, and maybe kind of the Bangkok or the central region of your country, you may want to create more subdivisions so you can get more meaningful comparisons. It's really just dependent on your population and how you want to split it up and compare it. And ultimately, you want to do a similar comparisons with facilities. So once again, Kalpana really talked about this, so I won't belabor the point. But when you register and define who you are, you need to be explicit. Are you academic? Are you community hospital? Where are you? Metropolitan versus suburban? What region are you? One of the 12 in Thailand. And then you can, if you'd like to include, for example, that trauma marker or demographic. So this is all very helpful because when you get that data back, as we're going to discuss now, that data can be displayed and it can be represented in a lot of different ways. So you get the data back, it'll be defined by region, by institution, by various different dose metrics, by protocol. Obviously they have to be mapped, and then by some kind of demographic, age, weight, size, and all of that information is provided in a structured executive report. But the beautiful thing is, and I know Nepapong mentioned that maybe this is phase 2 or maybe phase 3 for what's going on here in Thailand, is to provide the data in a way that people can manipulate it. So either online through a GUI that you can then log into some kind of website that's developed eventually, or even if it's just a minimum of sending them an Excel worksheet. So you give them the executive summary, and then you give them an Excel worksheet with their data and relevant statistics from the other 9 sites that you have. I know it's a little more rudimentary because it's just an Excel spreadsheet, but to give the data back to the people is very helpful to the hospitals so that they can actually make meaningful corrections going forward. So once again, here's an executive summary, kind of what it looks like. This was from my hospital, and this is for the adults. So even though we're a pediatric hospital, we do young adults and even adults that have had pediatric diseases, and they're just followed at our pediatric hospital over the course of their life. So the anatomy of this executive summary is it's going to list the RPID short name And so if you have 14 of them here in Thailand, you'll have your 14 listed out. It's going to give you the date. It's going to give you the dose, the dose or the statistics about the first quartile, the median, and the third quartile. And this, of course, is specific to your facility. And then it can show you a full year comparison and then a year to total. So little longer than just a full year. And then this is, Kalpana mentioned, all of the data here on the right-hand side comes actually from the DIR. So I'm comparing for my CT abdomen pelvis with contrast. We submitted that for Q2. So March, April, May, June, excuse me. We only submitted 39. And you can see here, that was compared to, good heavens, 3 million. And you can see here our median value is 4 compared to the median value which is 13. And then our 75th value, which is 6 compared to the 17 for the 75th value. So as you can just see that it gives you, as Kalpana really mentioned, when you're comparing your data to something with a sample size of million or multiple millions, these statistics over here are very robust. And so it, yep.
3, 4, and 6 are you're comparing, or is it like adult?
These are adult sized.
So these are under 18 but adult size.
These are over 18. They're adults that we treat or we image, but they're usually following
From
for
childhood.
childhood up. Yeah.
Interesting.
So
the
they're
dose
low
is so
dose.
low.
Oh yeah, yeah. We're probably in the 15 to 20th percentile. Yeah.
I have the same feeling because in my hospital, Riley children, when we scan adult patients that come to our hospital, we use a pediatric protocol and image quality somehow better than adult hospital.
Yeah.
And also radiation dose.
Yeah. No, it's when a pediatric radiologist, we've asked pediatric radiologists to look at noisy images for a very long time. And so they've become very good at it. If we take away their noise, they yell at us actually. And so we've just gotten kind of spoiled at those low numbers. So yeah, 3, 4, 6, you can see all down here. My CT brains, 33 and 35, which I think I actually have I'll show you some box plots in a minute. So here's my peds. And now, because pediatric doesn't make sense to just define one weight or one size, here you can see now for CT abdomen pelvis with contrast, they're broken up into those age categories as Kalpana showed. And so once again, statistics are all shown here, and then compare that to the DIR. Now, because peds, the sample size is a lot smaller, we submitted 24 in this category. It's being compared to just under 2,300. So still, those are pretty good statistics. In which case now, our median's 2 and the median nationally is 3. So we're pretty much in line with the national average for peds. We definitely skew lower for adults. So once again, Kalpana demonstrated this. The beautiful thing about having those plots, these tables, as I show you, you actually have the physical numbers. You can look at them. You get a real good, quick review. But you have to be adept at reading through a table and synthesizing that data in your brain. Whereas a plot is beautiful because it's a pictorial representation of what you have. And so the anatomy of a whisker plot, once again, just to review, you have your minimum and your maximum value. You have the first quartile, or the 25th percentile. You have the median, which is shown as a solid line. And then the mean value, which we don't rely as much on, because mean values can be skewed with the means and the maxes. So if you have a very long maximum whisker, you'll see that mean come up. In fact, that mean can sometimes pop out of the box and actually be higher than your 75th percentile. And that is why we do not use mean to compare it to national DRLs. So we have the median, the mean, we have the third quartile, the 75th percentile. And this is, of course, the value when we eventually calculate DRLs. This is what we're referring to as the 75th percentile. And then once again, as Kalpana mentioned, your data is shown pictorially as just a nice, simple red line. So looking at the anatomy of a couple box plots. So this is the 10 most common procedures that the ACR prescribes. Upper left-hand corner, CTDI volume. DLP is on the upper right-hand corner, and SSDE. Now, once again, I've said this before, you don't always have to submit. For number 7, for example, CT chest pulmonary arteries with IV contrast. You see there's no red dash. We do not submit for this. We also don't submit with CT neck with IV contrast. We do some, but most of our necks are without contrast. It's okay. And I stress that as Thailand brings on various different hospitals, it doesn't necessarily mean as an entity joining the National Dose Registry here in Thailand that you have to participate with all 14 exams. You could do hopefully most of them or half of them, or at least the 4 that are consistent for the Thai, 11 through 14. But nonetheless, you can see here the comparisons. SSDE is still being developed. You can see here, even though we can calculate SSDE for head, it's not quite been implemented. It will be probably very soon. And then once again, you can see just your red line, your institute compared to the national values of similar. So in this case, this is our adult data, and I didn't show our pediatric data. But there would be a whole separate thing, separate plots for the for our pediatric data. All right, you should always include with your report, explain the number of procedures or studies that were included in the calculations, so that you can get this interesting. It's kind of an interesting way to give a very quick ranking of where you're at. And so you look at your institution and how many institutions have doses higher or lower than yours, and then it can do a very quick ranking. And so you can see in the nation, among our pediatric pure hospitals, we rank 9 out of 10 for CT abdomen pelvis with contrast. CT chest with contrast, we're 9 out of 10, and CT head brain, we're 10 out of 10. Which is to say that means we are very low. We're probably one of the lower ones in those 3 categories. So you can include some kind of ranking system. It's not necessarily meant to be kind of like grades that you get in school, but it is a way to help instantly give you an understanding of where you fit with your peer institutions. All right, dose registry results leave from a dose monitoring system typically, but they don't go back to the dose monitoring system. They don't have that backwards compatible pipeline. So when you get your summary report, you will still have to go back to your dose monitoring system and manually enter in national DRLs or anything else that you may want to take from the registry report and put it back in your dose monitoring system. It's mostly just updating and keeping your DRLs and your achievable dose values consistent, as those do change about every 3 to 5 years nationally. All right, and then as I mentioned, the results need to be compiled to be easily analyzed. And we will talk more about this in a moment today and tomorrow, but you do need an analysis team. So Dr. Canal mentioned that physicists and technologists in the US work very closely to help standardize and get everything prepared to go up. And then when the data comes back down, that same group, technologists and physicists, will oftentimes now include radiologists and IT specialists. And that's the group that'll come together and analyze the data to make decisions. Because as Kalpana mentioned, sometimes you're at that threshold, you're either higher or a little lower, and the question is, what do we do with this data? And so you need to have all these key players involved, as I've listed here, so that you can make the right decision going forward. The right decision obviously is to maximize benefit for our patients. All right, in summary, the Thai National Dose Registry has been developed. We've seen some introductory reporting. So this is a great first step. Well, it's not even a first step. It's like your second or third iteration on this. And so you guys have really developed since the time that I started doing this a couple of years ago with you. The fact that you have national dose reports is a phenomenal thing. You guys have a one-page summary, which is a great way to talk to physicians or to radiologists. They're not going to spend a lot of time trying to understand it all. But to give a formal first page is wonderful. But obviously there were other things that were included that we discussed that you should consider putting into the larger body of the report, because maybe the majority of the people reading over that will be people that are chairs. They're too busy to go through the entire report. But there's always going to be those people that are very interested in being a part of the dose optimization process. And though they may not actually do it, they may be the ones with the authority to give time for radiologists to help, or to kind of guide and direct the technologists and the physicists to help out. So keeping the physicians and the leadership, like the chairs of your department, involved is a great way to make sure this is a successful enterprise. All right, give instructions on how to interpret the data. And finally, the data will need to be analyzed locally. It absolutely has to. If you've gone to all the trouble to get the data up, to get it formatted, to get all the RPIDs set up properly, and then the data comes back, it's in a nice report, and it's left on the table and never looked at again, it was all for nothing. So you need to establish a process of receiving that data and analyzing so that you can make meaningful corrections. So that's all that I had. If there's any questions.
Thank you so much. Any questions, comments from the audience? We don't have any questions from the online participants.
Okay.
ค่ะ เชิญค่ะ So the question is, normally when we scan the patient, we're going to have the structural dose report that's sent directly to the DIR, to the center, right? What if we don't have those structural report? How can we do make the dose or the registration or something happen?
Right now, for the American College of Radiology Dose Index Registry, if you don't have the DICOM structured dose report, you send a screenshot of your dose report. So it's just a screenshot, and then they use software to read that dose information right now. No, they do it in automatic fashion. Yeah, just
Kalpana?
right there,
Yeah, like this. So this
like
would,
that.
this would go up, and a computer would go in and recognize the characters, and it would read out. So series 2, helical, range, dose, all that stuff would come out.
Yeah, it's called OCR, right? Optical
Coherent
character recognition.
Character or coherence.
Something like
recognition.
that.
Yeah.
So yeah, the software does that and reads it out and deposits it for that facility in the DIR. But when I talk about on Friday about the future of registries, that is going to go away in America for the DIR, because I think most modern scanners now have DICOM structured dose report.
Yeah, they do. And there's being mandated, I think, at the IEC level. So all newer models have to have it. Yeah.
In Thailand, what is your database for your CT scanners? Is it mainly old scanners? Do you have newer scanners here?
Yeah, I think Napapong said for like the rural communities, they may be more 4 and 16. I know of the 2 hospitals here in Bangkok I've shown, they were all top of the line, 32 slice, 64. No.
At the moment, even if we do DIR now, it's going to be only a very few hospital that doesn't have this structural report to send us, and they will not participate anyway.
Yeah.
There is a question from the online. If you have more than one CT scanner, do you compare each scanner dose with the national registration or just the whole aggregated hospital dose with the national?
Yeah. I know Kalpana mentioned, and she showed in one of her examples where she found one of her Siemens flash scanners was a little higher. But yeah, you can do, let's say you have 10 CT scanners at your hospital. You send them up, you're defining the protocol, you're defining the scanner, you're defining at very different granular levels. And then when through the ACR, you can look at that. That's one of those things that maybe here in Thailand, then that would be tricky for you guys because you don't have a portal to do that. But if you sent the data back in an Excel spreadsheet, then they could have that. But on the executive summary, the page, some of the images that reports that Napapong sent to us, the current doesn't break it down by scanner. So maybe going forward, if there was a way to take that data and collect it and put it into an Excel spreadsheet, then the participants in the Thai National Dose Registry could then see how one scanner compares nationally to all the other scanners. Okay, so you do have specific, that's great. So Napapong says you do have specific data specific to the scanner. That's
Yeah,
great.
but just to point out, the executive summary that you get from the DIR is showing you the dose for across all your
all
scanners.
scanners, yeah.
So that number, if it's 56 is the DRL for an adult head, that is across all scanners. But if you want to look at it, if you want to see if one of your Siemens scanners is higher or G, then you need to have access to your data either through the DIR or through your dose management system, which it's very easy to figure that out and see if one of them is running hotter than the other. And that's really valuable data actually, because it might be that one scanner is set to give more dose for some reason than another scanner, especially older scanners that don't have the dose reduction options. You might be running a little hotter. Like I'll give you an example for us. At one hospital, we have all GE. At our trauma hospital, we have all Siemens. Now, Siemens head image quality is fantastic compared to GE. So our head dose on our Siemens scanner is around 45 milligray, routine head. On the GE, our routine head dose is 60 milligray because my neuro doctors do not like image quality from the GE. So we had to increase our dose a little bit for them it to be acceptable to them. And that's fine. To me, that is meeting their demand of their concern for image quality. I'm still way below, or well, I'm a little higher than the DRL. It's 56, I believe, for routine head, but I'm still way below the ACR accreditation limit, which is 80 milligray. So as long as you know your scanners and the usage and what the need of the radiologist, you could justify that. But yeah, we are definitely hotter for our GE scanners compared to our Siemens scanners.
Hafong, can you sit over there? Right. And I mean, people want to hear from you. So
I think from our experience, the team with Dr. Panadita and other stuff, we really put emphasis on the dose together with the image quality.
Yeah,
because
that's great.
we get into trouble from some of the sites when the radiologists start calling me because they know me. They just call me, Napapong, take care of this for me, please. I said, what's happened? She said, the radiologist said she cannot read the head and neck CT at all because when the ministry announced the DRL value, the technologists across Thailand, they reduced the dose. And this thing really alarms us. That's why in this course, we kind of bundle together. Like if you look at the dose, you need to look at image quality too.
About what Sam was saying about having an analysis team to interpret the data, right? And that's what you just said, that the technologists may drop without making that connection with the image quality, right? So you have to have people who understand the data. And just because you have a DRL doesn't mean you have to adhere to it if you have a good reason not to.
Yep.
Like we do for our GE scanners, we are high, but still very low compared to the accreditation limits, which is 80 milligray in the United States for an adult head. So you really have to have that team, and the knowledge is very important. And in this country, as you said, technologists are doing more than physicists. There aren't that many. They need to understand the physics behind it and how to use that data, and pretty much have to do what we do in the United States to make informed decisions. You can't just go with a number and reduce your dose. You have to work with a radiologist. Yeah, you have to ask the radiologist, work with them, and make the decision accordingly. So.
Is it true that right now in the US that you need to send like a dose report or something to get the reimbursement in every patient? The dose report data, like the DICOM things
No.
or you need to put that things in the report to get the reimbursement.
So in some states, it's required. For example, California, it's in the law that the dose information, CTDI, SSDE, DLP, is in the radiologist dictated report. It's not required in every state, though.
Also.
You know why that?
Okay.
The reason it is in California, if you remember, both Sam showed those slides and I did about those patients, the stroke patients who had the overdose and the child who got scanned many times. So that all happened, I think, within a year of each other. And so California state, the regulations, that's why you have to be careful of regulators. They came and said, now for every patient, you got to put this in the radiologist report, which can be tedious and annoying in a way, because the interpretation of that could be anything by whoever is reading the report. So in a way, that was one extreme case. Thank God no other state or not a lot of other states did that. But that's something you have to be careful about when you invite regulators and government. They put the law down, but then I think there's a problem. It depends if the parent is reading the report and they freak out. Oh my God, this number is so much higher, right?
Well, that was the problem, because the state came out and says, thou shalt put the patient dose in the report. But CTDI vol, DLP are not patient values. And so immediately the radiologist said, well, what do we include? And that's actually where SSDE was developed. It was a need to create some kind of patient-specific dose, even though technically SSD is still not patient dose. So you have to be careful. Regulation will drive changes that aren't meaningful. So you have to be very careful with that.
Regulators have one agenda.
You have reached your limit. You cannot talk anymore. Yeah, not in the U.S. In the U.S., it's the opposite. No, it's not on.
Thank you. So in my state, in Washington and United States, we had no CT regulations. So I wrote a letter to the state saying, you have regulations for radiography and not CT. What's wrong with this picture? So after, really irritating them for a few years, they invited us and all others experts around the state, technologists, physicists, administrators, radiologists, and we came up with the regulation. And we said we don't want to be like California where we require it in radiologist report, because we don't want that. And then they did that. And so it's very recent in my state that we have CT regulations. But you have to be careful who you involve in, otherwise if you lose control of the process, then it's going to be really hard to do what you want to do for your DRLs.
I think it's time for coffee.
Okay, so we're gonna have like maybe 20 minutes coffee break here, and we're gonna take the photo for the online audience, and for us who on site, we're gonna take a photo later. So grab the something
After
to
the
eat.
caffeine.
After caffeine. No caffeine. I'm so sorry. Just like a cake. No caffeine. You want some caffeine? You want some? Okay, so we're gonna come back and see each other again on 10:30. Yep. For the people on the online, if you want to like open the camera and we can take the photo, your photo. เปิดกล้องไหมคะ